What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab. Hey everybody, this is the Breathing Lab by Dr. Jenny. I'm here to interview Dr. Harry von Piekartz. Thank you so much, Dr. Harry, for coming on our second interview together.
Yes, now it is perfectly.
The first time we did this, unfortunately, we had a problem with Harry not being able to connect. And now everybody from Europe is able to connect and we have the settings right. So thank you for being patient. And I wanted everybody to see Dr. von Piekartz because he is very vibrant and a good speaker and answers these questions that I have that aren't always easy, very well spoken. So thank you, Harry. I'm going to tell everybody a little bit about yourself. Harry is a professor at the University of Applied Science in Innsbruck, Germany, and is study director of Master of Science in the Musculoskeletal Therapy. He is a senior IMTA teacher of the International Maitland Teacher Association and founder of the Craniofacial Therapy Academy. That's the CRAFTA Academy. We're going to hear a little bit more about that soon. He successfully completed his Master's of Science degree in the physiotherapy at the University of Leuven in Belgium. With his thesis was on the neurodynamic testing of the mandibular nerve, reliability and norm data. In 2005, he received his PhD in rehabilitation science on the Staffordshire University in the UK. His thesis was in neuromuscular characteristics in pediatric headache. He directs several musculoskeletal research projects and works part-time in the specialized clinic in Utrecht.
Very good.
And in the Netherlands. And in 2023, he got his certification as a certified temporomandibular therapist by the Physical Therapy Board of Craniofacial Therapeutics and Cervical Therapeutics. He published 4 books in 3 languages and more than 100 peer-reviewed articles in the field of craniofacial physical therapy, pain and motor control also. And he specialized in neuromuscular skeletal assessment and treatment of the head, neck, face impairments, and pain. So everybody, I am so happy to have Harry with us one more time. I'm going to share just a few slides, Harry, so that you can take a look at what I have. Part of these slides were going to be when we did this with your friend and colleague and my mentor, Jan Damerholt. So I'm going to share here. I see.
First, Jenny, I want also to thank you for your invitation to be here and to discuss with you the topic about orofacial pain. I hope also my language is okay. I'm not a native speaker, but I'm a Dutch English speaker.
I love the accent.
Mostly hear my accent that I'm not really coming from the US, but I hope it is clear.
Oh, yes, you were very clear. And that last podcast interview, you did amazing. So I'm very happy that you're here and I think everybody can understand you. So welcome, everybody. Here is our podcast today. What we have in common. I went to school in Holland and Amsterdam, and Dr. Harry is Dutch. I went to the Hogeschool van Amsterdam. And so Koen van Stralen, I knew. It was such a great experience for me because they're all manual therapists there. And I started touching very young in my career, and I loved it. And so I got into orthopedics later. But Harry's obviously works in Holland. He's a professor in Germany. But here is Harry and all of the Dutch PTs at, I think, one of the first CRAFTA courses that you taught. I missed that one.
It was I think it was in 2014. Then there was a soccer play from Holland. And every Dutch colleague who was living in the US was also looked to this match. And therefore, everybody took out some yellow T-shirts. You see here.
Orange.
Yeah, we are done very national. You see this.
Yes. So, and of course, here too, my mentors, Mariano Roccabato and Jan Dammerholt, um, and Harry. This was in Madrid, I think.
That was last year in Madrid. We had a very good conference over there for physical therapists and head and face pain. And it was a long time that I saw Mariano Roccabato again. Jan Dommerholt I see regularly because we have in Bethesda also the CRAFTA courses over there. And Jan and I did a very nice, I think also a workshop before about dry needling or facial pain and the manual consequences of it.
Right.
So it was very interesting. And also was very nice to see Professor Mario Roccabato. Again.
And I know you're going to be teaching with him soon, right?
He's coming on the CRAFTA conference in 7, 8 June. He does some talks over there in a workshop, and then afterwards we have in that week after 10 and 11 June a course in Holland with him, and then also in Istanbul in Turkey, where we go to the whole process of oral cervical complex assessment and treatment. So from the beginning up till now, what has changed? We know that Mariano started with it, with this biomechanical concepts about the relation between TMJ and cervical. You want to prove it, you have to measure this. He did this already on a very short sample, but did facilitate dentists, but also physical therapists to look to the TMJ more and the cervical spine. And I think this is one of the basic where it starts with. And then later also, for instance, Stephen Krause came with his book in 1988 and 1994. That was also a very good facilitation for physical therapy in general. So my first time that I saw Mariano was in 1994. He gave a conference for dentists and physical therapists in Amsterdam. And it was amazing. Wow. It was for us amazing. So and that facilitated me also to go further with orofacial patients, because I was then a young physical therapist, and nobody wanted to treat this group. We get a lot of people from orofacial surgeons, and I was the youngest in the practice, and say, "Hey, Harry, you have to do this." But it was also my interest, so it was a win-win situation, and so on. I get all the people, in the environment. Probably you also know, Jenny, you do also a lot of orofacial pain, and then people come from far away.
Right. Well, you tend to see repeating patterns, right? As you see different types of patients, patterns will repeat. And for me, the combination of treating with a dentist that understands what we do as physical therapists that really get the spine and the TMJ and the cervical area, that it's truly very magical what happens, I think, with patients. It heals them, but not many dentists understand that connection or have the education around how we could work together. So this is really a great opportunity for, we'll be talking about the CRAFTA course at the end, but this is to bring a lot of dentists are going to be watching this, and it's really to make them understand that it takes a team of people that know the general area and are experts in their part. And then you combine it, as long as there's good sequencing and good communication, it's great. So I'm excited that you're doing that too.
I have to say that this weekend was the AAOP conferences for dentistry, but there were also a lot of physical therapists over there. And I hear that also from dentists over there, and also from physical therapists, that it was a good conference. And also there was a good professional attitude also from the physical therapists over there. So our colleagues. And this is maybe also a good basic for cooperation in the future. To cooperate with dentists and look what we do. We have so much things dentists don't know, but also controversy. And that would be good. And maybe a little bit early now, but that is also why we organized this conference in Hamburg, where we say physical therapists meet dentistry, to make this communication, this cooperation better.
Yes, yes, yes. Oh, okay. So I took CRAFTA
That's my colleague Michael
Trau.
Yeah, he gives
was
also
wonderful.
the courses in Bethesda. Yes.
Yes.
Okay.
So Myopain Seminars is who hosts and brings CRAFTA over to United States, and that's Jan Damerholt's company. So if you're looking to take any of these courses, you look up Myopain Seminars. I had very different hair then. This is Marissa.
Oh, is that you? Okay.
Yeah, that was me with the dark hair.
Okay.
But,
yes.
And this is
nice.
Marissa. So I took CRAFTA 1 and 2, and I loved the course. Here I actually met Jennifer Nelson, who I know also teaches with you now.
So she's now in the teachers' education. Yes.
Wonderful. And then this book, if anyone does not know about this book is an excellent textbook on craniofacial pain written by Harry. You can get this at Amazon. Amazing book. First thing I wanted to tell everybody, we're going to do just a couple of case studies, just so that the audience understands kind of what a physical therapist does for different types of problems that we get referred. So one is an orthognathic surgery case. I had a young 23-year-old that had very similar problems that I have coming in with TMJ, like headaches, facial pain, chronic fatigue, very tired all the time, feeling like she just can't get a good night's sleep. But she was diagnosed with sleep apnea at 23. Not many people think, and she looks very normal, but she's a young 23-year-old dealing with sleep apnea. Her airway was the size of a coffee stirrer, very, very little. So we identified that she was a mouth breather, and that she began having problems with placement of her tongue because her palate was very high, very narrow. She wasn't using her nose. She wasn't using her diaphragm. But because of all this, she decided to have surgery. And the surgery is a pretty big surgery. An orthognathic surgery is when they reconstruct your face and your jaw and reset your palate and your jaw position. But this is really to tell you what we do as physical therapists that work with the oral surgeon and maybe the orthodontist, is we do a lot of head and neck manual therapy to improve what we call the cranio-vertebral angle. That's basically how your head and your neck fit. What position are they in? Are they in good lordotic curve? Initially, it's a lot of lymphatic drainage. PTs use their hands a lot. The ones that are manual therapists even more, but we're trained to redirect the fluid that gets pulled in the face after surgery. We work on facial exercises to move that fluid and to activate these muscles. We work, at least my office, we have speech therapists and physical therapists that are trained in myofunctional therapy, which is training the tongue posture, and the function of the tongue is the swallow and chewing and moving food and creating boluses, creating the right way to chew. Like, eating is a skill. Not everybody, even without surgery, eats well, in my opinion. But we do a lot of sleep training. We try to work on patients' ability to sleep in proper positions. But in the end, she did great. So here's her case. She's 23. You notice a very long face, very, very long and kind of sunken eyes, big forehead. And the lips are, you can see that to close her mouth, she has a lot of tension in her chin. And she's just feeling very, very tired. And she gave me permission to show this. So this is Megan. Very forward head posture, rotation of the skull on the first vertebra, recessed jaw, doesn't have a good jawline. You could see that her jaw's falling back into her airway. This is the surgery that she ended up getting, the Lefort segmental osteotomy, bilateral sagittal split osteotomy, and a genioplasty, where they bring the chin forward. This is just a little bit of the pre-orthodontic pictures of, she had an open bite, she had a tongue thrust, the thrust of the tongue every swallow created this bite. She had a little bit of a deviated septum here. Let's see, this is just 2 weeks post-op. So right now you can see there's a lot of swelling that occurs. And for me, the swelling is what makes people think they don't want to be out in public. They're ashamed of it. They're afraid of what people would think. So PTs that are trained in orthognathic surgery help these patients. A lot of surgeons don't know we do this, but the surgeons, they cut, they do their job, they do it well, but then the patient's left with a lot of swelling and weakness and kind of fear to function and to be out in society. So the initial phase of treatment is a lot of postural re-education and lymphatic drainage. That's what we do. So a lot of these facial activation of the muscles. If you think about it, all these movements, looking really wide-eyed, close your eyes tight, that moves the fluid from the forehead. It starts to mobilize it. This one, I say, get angry here. So this wrinkles here, it helps this drain. And bad smell, you smell that, you wrinkle your nose. This one's, you lower the upper lip. Here you pucker, here you frown. And this one is the platysma. You activate your platysma. This is the area, stop for a second, when we train the patients to do self-lymphatic drainage. And Harry, you can tell me if you do this type of work too, but we move the fluid to the ear, and just where the lymph nodes are kind of collect and drain the fluid here and here. So there's a lot of techniques that we will bring the fluid, and if you do it, patients look normal much more quicker. This is just another quick picture. 6 weeks later, some exercises or techniques that we do outside of the mouth and inside of the mouth. After 4 weeks, we go inside the mouth. It's like the bones have healed a little bit, enough to put a little pressure on the TMJ to do some mobilizations. This is some extra oral mobilizations. We teach the patients how to do some exercises where they are actively moving their jawbone to help protrusion. For example, this is the hands in the back of the jaw, angle of the mandible, and bringing the jaw forward. And she's here also putting her hand on either side of their jaw, actively moving it one way, because sometimes the joints get stiff. Sometimes the way the surgeon cuts, it will tighten up the capsule. So we need to make sure that we are mobilizing the mandible and the TMJ. And she had a tongue tie. So this was in 2015. So they do a lot of stitching now. This was the time that they didn't stitch after frenectomies, but we trained the tongue before and after the frenectomy. They decided not to do it during the surgery, the big surgery, because you're wired shut for a period of time, and you don't want to do tongue exercises while you're wired shut. You need that flexibility. So we ended up deciding to do it at about 6 months or 3 months later. This is just taking some measurements. And really quickly, this is the before and after. Her bite, her profile is so beautiful now, but lips open, lips relaxed and closed. And here's very interesting. This is her airway, very compromised before and more open after. And so she was just very happy. Afterwards, she just felt like she got her life back. So I'm going to go back. So Harry, tell me a little bit about your treatment for orthognathic pre-post.
Yes.
It sounds similar to what we do in my office, at least.
First, I want to say you compliments about this case. This is very nice to see, and also for her, and that she can back her face what she wants, probably.
Yes.
See also these patients. They come from a special hospital where they do this. Where they have this Le Fort operation, and they mostly have open bite. And this girl had also an open bite. And what you also saw in your nice pictures, you had the cranium was rotated posterior. So if they have a headache, always have to look to occiput C1, C2. Yeah, that's one thing very important. Because if you have a rotation of the head, your tongue goes lower, yeah, and the tongue comes not to the palate, yeah, and because you want to also to facilitate breathing to the nose, yeah, you have to correct mostly occiput silon, and what you say, correction of posture. And so try to stimulate the breathing, but through the nose and out through the mouth again, yeah, as a rhythmic exercise. That's very important. One thing is also important, if they have pain, there are two things what we always ask. Do you have pain? And do you like your face at this moment? Are you comfortable with your face? Because a lot of mostly young girls are not comfortable with their face, and they say, okay, I have a orthognathic jaw, maybe my jaw goes to frontal, so I get more power in my face. I get a better face afterwards. So the question is always, if you have no pain, do you want to have this operation? And mostly I have contact with one surgeon. She sent me these girls before the operation. So they get to choose. Yeah, they can choose, do you want to have this operation? Then they are by us on the treatment. Not so much, one in the three weeks. I explain everything, do my work, or facial respiration techniques, manual therapy. And then I look, can we control the pain? And then afterwards, this question comes again. Yeah, and let's say 50% of all the young women who I saw don't choose for the operation. Yeah, and they're very happy with their face. And we discovered also now in new research that a lot of these young women have a kind of a body disruption. The somatosensory information is not integrated optimal in brain. Yeah, and therefore they get also other sensory awareness like tinnitus, vertigo, tiredness, and also facial expression is changed. Yes, my accent is laying first on this part, and especially if you say also very nice lymph drainage techniques, could be very appropriate. But if somebody has this after the operation, in Holland they go to an Udane therapist who are very specialized in it.
Okay.
Yeah, they do the whole day, nothing else. They do arms, legs, and face. So I have a connection here, not far from here, from my practice, who do this, and because he's a specialist in Udane therapy.
Yes, lymphedema therapy. Yes, we have that too, but not everyone is trained here.
No,
They're more trained in the breast area.
Yeah, but she is also doing a lot with cancer patients. Yeah. So and this is also a kind of a good opportunity for her. And then afterwards we combine this. And I don't know how. Probably you also saw this patient for 5-6 years, I think, huh?
This patient
trying to five. Yeah.
Solutions for her, and so I think the sleep apnea was not identified. People are not aware of how narrow the airway can be with these young people. They look. You could tell she looked exhausted, and you don't sleep well for years and years, you're going to look like that. But that was it.
And did she have also pain? Did she have pain or not?
Headaches.
Or discomfort? Headaches. Yeah. Where were the headaches?
Headaches, temporal headaches, and a lot of clenching. A lot of clenching.
Yeah, of course, because this is what you see as a reaction of increasing trigeminal sensitivity. Because the diameter of your nasopharyngeal region and your sinuses are smaller, you get more aerodynamic pressure on the mucosa that can increase nociceptive inflammation. And you know about the trigeminal-cervical nucleus, adapting with cervical and the face, this can give a chronic pain, together with a facial dystonia, what you also saw in this very nice patient, or a reaction from fight and flight. It is bruxism. Yes, so the respiration is very directly also correlated with the motor expression, and it can be inhibited by facial expression, or you can get more an increase of tone, yeah, and therefore also para functions like bruxism.
Yeah. I from one of the things that I always bring up with patients, there's some research going on with ENT world around clenching and the causes of clenching and why bruxism is there, but upper airway resistance is a big one. So not being able to breathe through the nose, having too much resistance to nasal breathing, causing a collapse in the airway in the pharynx. So, so one thing we're going to bring up is oral posture training that we talked about previously, the up lock position and the up blocker and the device that I help people just learn how to support that. I think
wonderful.
Is a very good tool for these patients. And these patients are, I think, one of the worst breathers, but they're not educated by the oral surgeon that they're coming in with a dysfunction in their body because of how they breathe or how they swallowed. You know, the ENTs and the surgeons don't really correlate those two things always.
Because what you say also with these devices, you have to also look to the normal posture. Yeah. So if you breathe and you have more extension, it has no use. Yeah? Or also when you think about posture where you can get more diaphragmatic respiration together with this device with giver resistance, it is more a good training. And that is not probably done also by ENT doctors or facial surgeon. Maybe good to know that we did last year a narrative review in musculoskeletal pain in practice with Professor Susan Olivio and Dr. Hedwig van der Meer. And we looked to the literature, what can cause all oral facial pain. We saw a lot of literature coming from the ENT world, what gives them chronic pain bilaterally in the head. And what is mostly also referred first to the neurologist. Where people have no problems over here. And in my opinion, I don't know what your experience is. If you do some facial bone techniques, you see that for instance, the respiration is reduced, but you also provoke pain. So there's an increase of nociception. And this probably goes together. And that is not during life. If you do an inspiration, expiration, you have no pain. But if there is a little bit more pressure on the facial bones, because they have also nociceptors, of course, and they go also to a part of the brainstem. So there's an efferent barrage together with the mucosa, who is a little bit nociceptive. And they accumulate, and that can give an increase of pain experience. And it is what you not see on X-rays or MRTs or something. And there is good literature about this, but we don't hit this literature. We use this normally not.
No.
When people are now are interested, I can send you the article, the narrative review, and then everybody can read it as an overview. Is, I think, very nice.
Yes, I will send a follow-up email with anything that you want to share, and we can. Whoever hasn't seen the needs to see the recording can see what we did. So I'm gonna keep going, Harry, real quick. Let's talk a little bit about just in 2000. When was this? 2019. You reached out to me. I think Jan connected us, and you referred Taylor Tashima, this very sweet Swiss pro volleyball player. She had 2 concussions back to back. And she's someone that was looking for solutions because she was in a very, very bad way. This was something that, actually, I took this picture at one of the CRAFTA courses with Michelle Layton, was one of Jan's instructors. But she allowed me to do this technique tour. The nasal release technique, we've done a kind of a pilot study last year, and we're getting it. It's reviewing to get published, but it's a very effective technique to decompress the head in 8 different positions. You put it on the right side, left side of the meatus, and of the septum, and different parts of the skull get decompressed. So that was one thing that Taylor was able to experience with practice. We did 6 weeks of treatment and 6 nasal releases. And by the way, part of the head even cracks a little bit when you do this technique. The technique is a very simple technique with a balloon in the nose. But we also did the cranio-osteopathic manual medicine. I know you also include that type of training to your CRAFTA courses. But that was very, very effective because any compression or blow to the head changes the way that the bones fit in the different sutures. And then also we did some dry needling. Jan sent me this picture because I think in one of your courses, you had said to him, how are you going to get into the lateral pterygoid? So Jan sent me this picture, but this is a very effective technique to release the tension of that muscle that connects to that disc. So, okay, we can talk about.
So maybe, Jenny, maybe I can, because of this girl, I know this girl because I sent this indirectly to you, huh?
Yes.
Because because my daughter is a professional volleyball player, and she's playing.
Wow.
And therefore, therefore, and she wants to. I told her she lives in the US, and she first wanted to come to Holland, but I said, you can also go to your institute. So you did very well with her, and I heard from my daughter that she was very happy. Yes.
Good.
Maybe
Good.
can I shortly one of the techniques, because we have less time. This here. I hope you see this. This is on the right side. You see here the narrative review. As you know, we look to these techniques nearly the same what you use. Yeah, we look to the zygoma bone, the frontal nasal bone, and the palatinatum, together with inspiration, expiration, and alpha nervus. Yeah, we know that, and that together with swallowing, it can collapse. Yeah, the space, the tube, but also in a sinus. And then you start with respiration. For these techniques, they look very awful, but they are very fine. Yeah, we try to reduce the nociception. Yeah, you have one choice: or you reduce the nociception, or you change the respiration, or of course is both. And then afterwards you see this very good results mostly. This also some, as I know you probably know this technique, these articles. One is from Sanchez. They did it also in a Spanish group. Yeah, Francesa Femas La Penas. They did it by chronic rhinosinusitis, case studies, and training for manual therapy in combination with exercise, with a signal good effect over long term. And I think also it doesn't matter which technique you do. If you change the respiration and the pain, then you are in a good direction, I think.
Yes. I'm really excited to hear about this CRAFTA conference, Harry. I'm fortunately not able to go, but I'm going to listen in because it's able to connect online. So I want to share with everybody, this is happening soon. So if you're interested in learning from Dr. Harry and the European, you can tell us a little more about it, Harry.
Yeah, so we have, I think, a good of experts in the field. Professor Jens Turp, a dentist, who talking about dentistry and communication. Professor Corine Fischer, she is from Holland. You see that here. Who is talking about physical therapy in combination with orofacial pain. Dr. Roger Carey is coming about the red flags in craniofacial pain. Professor Susan Armillo about the new strategies in rehabilitation is also very interesting. And then Roy de la Touche, he's one of the best, I think, reviewers also at this moment. Goes in what is the effectiveness of exercises in orofacial pain. And then at the end, Professor Andrea Michelotti was talking about dentistry and in pediatrics. and then Mario Rocobado. So we have, I think a very interesting program. And then the day after, there are all workshops. And all these workshops are also filmed. So you can follow every workshop. If you are not coming to Hamburg, it doesn't matter. You can follow it online. And you can see all the videos 3 months afterwards. Yeah, and you get also, of course, a syllabus with articles and so on. So it's very exciting for us because we translate this also directly in German. Yeah, because the most German cannot follow English very good. Also in Turkish, yeah, we have a group of Turk colleagues, and probably also in Polish. So the main language is, of course, English. Yes, somebody else interested, please join.
Yeah. I'm really interested in that. I'm sad that I can't. There's still a chance I might be able to go. I don't know.
I can imagine it's a long time, but
yes. Okay.
But you are in the east of US. To add that to the east of Europe is not so far. It's only a little bit border.
I am going to Holland for sure next King's Day, by the way.
Oh,
I just rented a flat, so I'm excited. It's for our 20th anniversary, my husband and I with some friends. So
good.
Okay,
nice.
I'm excited. I have let's do one more thing. Anybody has questions, this is your time. I'm going to ask a couple questions. This is from Anne Weinsel. It's TMD. Why do some patients have pain and others not? But the disc displacement on MRI or clinically the same?
Yes. So that's a good question. Yeah. It's the same question Professor Jens Sturp asking. Why have somebody a bad occlusion? Some have pain and some not. Same is for us also. And so we know that it's the same in the hip or in the shoulder and the lumbar spine. There's no correlation with dysfunction and pain. And there are a lot of risk factors who can maintain the pain. One thing can be stress, immune system plays a role. Maybe also, let's say, the biomechanical components from it. Some things are also genetic. But there are some people are predisposed, like females have more orofacial pain than men, for instance. And you see also more orofacial pain and TMD problems between 20 and 40 years. That is the epidemiology, what you see. But there's a summation of a lot of risk factors. And therefore, it is also so difficult. And I think also the first patient, what Jenny showed us, is also a patient with a lot of risk factors. And then comes the operation, and then the pain and the dysfunction stays. So I'm to say, the risk factors play a very important role by maintaining TMD problems. So on the one side, and that is nice in physical therapy, you have to be a lot of hands-on, but also a lot of coaching and training together with the patient.
Yeah, and what I feel like makes the difference between these patients with pain or not pain is that some are clenching, driving more compression in the joint, especially the area of the posterior aspect of the joint where it's more highly innervated, versus some might not be clenching, not squeezing that area that hurts so much. So bruxism, I'm always going towards the side of airway being narrowed, causing issues with wanting to have the tongue. If my patients that are clenchers, they tend to have their tongue low in their mouth and they are clenched throughout the day and night. But the ones that we train, and so a lot of training, a lot of changing bad habits, and changing and transforming an airway and stabilizing it, you have to create a light suction back here where the tongue creates a suction without losing any air around the tongue. I say people you can't tell what I'm doing with my tongue in my mouth. My mouth is closed. And if my tongue is down, you don't know it because it's closed. But you can train it with creating light suction either with that little device called the vacuum activator. I also have people do a lot of stick under the tongue, a little Starbucks stick with a create little suction above it. That over time, my bruxers stop clenching so much and the pain reduces. So I think compression is part of the picture of these patients that have it or don't have it in terms of pain.
Yeah, but maybe come back on the question of our colleague over here. Yeah, you see people who have bad posture, bad respiration, but no pain. Yeah. So I had the same in bruxism. 60% of all people have a kind of an parafunction. Yeah, 40% had a night bruxism, but a small part of this 40% have problems. Yeah, there are a lot of contributing factors over here.
Yeah. One more question. What are the consequences long-term of the use of Botox for bruxism? Botox bilateral of the masseter muscles was the question.
Now, maybe I was on a conference in the German, let's say that's the German AEUP, the Deutsche Gesellschaft für Funktionsdiagnostik. Those are dentists who also cooperate with physical therapies. They do also functional analysis of TMD. There was one, I cannot remember her name anymore. This was a very good surgeon. He was doing a lot of Botox. He did also a lot of research on it. And the problem is with Botox is that if you get an inhibition of the muscle, the nerve make a sprouting after a time. Yeah, so the nerve is inhibited. There's no information anymore to centrally, and there's also not a contraction. So the sensory motor coupling feedback is gone, but afterwards you get a synapse going to the other part, and then the contraction comes back again. So the nervous system adapts. And that is near already after 2 or 3 months. So she said also you can inhibit Botox with bruxism when it is extreme, especially also by trismus, for instance. But the nervous system adapts, and if the patient gets back after a few weeks, you know already there's that's say normal physiological adaptation, of the nervous system. Yeah, so let's say for long term. There are doubts about the effect of bruxism, Botox. Yeah.
I always say it's it's not the first thing I go to, right? I want to transform the function of breathing, the function of airway support, and it's not something that I don't do. I just don't go there right away. But if you need pain relief and you can't get it through trying craniofacial therapy and you haven't found relief, I've found that some patients do well with it. I don't think long term it's the right thing to do forever.
Yeah.
But
so maybe shortly, because still about bruxism, you have to divide it in night bruxism and awake bruxism. The night bruxism patients, they use a lot of Botox, because they sleep bad, they get bad respiration, and so you get a feedback loop was very negative. The awake bruxism patients, you can manage very good with physical therapy, and we have now, we are very happy. We get an article in the Journal of Rehabilitation now. It comes out in June, where we looked to patients who had an awake bruxism, and we treat them with physical therapy and also with bruxism neural education. It was with respiration techniques, stool reversal techniques, wiggle techniques, relaxation techniques, that they get it under control. And this group was signaling better after 6 weeks. It was only with coaching and 6 times physical therapy. Yeah, and especially also here, the education seems to be very important, what bruxism is. Yeah, and then you come back on your story, Jenny. So then this goes together with a good respiration, with posture, but also neurophysiological. What happens in the brain? Why does this motor output is so contracted and can give you problems, and that they see that it is in several situations on the job, or not in sport, for instance, but also in stress situations or in intercommunication with somebody else and so on. And that is a very important thing.
Yes, yes, it is. My goodness. So I have just a couple more slides, and we'll be done in just a moment, and we'll be able to say goodbye. One of the things, there's a course that I'm teaching. It's a Rockabato course, an advanced course next week or next month in St. Augustine, Florida. So if you're a dentist and PT that wants to get into this field and understand a PT point of view, or you want to, treat this population, this is a great place to start. I'm also working on courses on developing how to educate more of the medical and dental and myofunctional therapy fields around what PTs bring to this field in terms of treatment and collaboration. And if you need to get a hold of me, this is how you can reach me. I'm going to stop share right now and say, Harry, thank you so much for coming and spending time with us today. I would love to do it again in the future. If there's ever an opportunity, we can do it in a few more months, 6 months or so. But that would be lovely. So
would be lovely. Yes, no problem.
I look forward to being a part of the CRAFTA conference. I hope present, but it looks like I'm going to be listening. But good luck to you and all of the great speakers. Thank you so much. And
also thank you everybody who was there and who was interested in this talk.
Yes. Thank you, everybody.
Thank you for listening to the Breathing Lab with Dr. Jenny.